three stages. The stage 1 is sleep onset. Stage 2 is the first stage, solid sleep. Stage 3 is delta or slow wave sleep. So these are measured by brain wave recordings. So we know that the person is now in this stage of sleep. The rapid eye movement sleep. Now, this is very, very important because many of the sleep disorders occur in this stage of sleep. What happens is your body is paralyzed during REM sleep, but your brain is active. Your eyes move, so that's why it's called rapid eye movement. Okay? So, but the muscles are paralyzed. It is at this time that the airways, the breathing tubes are most vulnerable, and any problems sort of related to sleep or breathing muscles, they start manifesting first at this stage of sleep. There is a wide variation in the breathing rate, in the heart rate and blood pressure, and there are vivid dreams in this sleep. But this sleep is important because the psychological rest and emotional well-being is sort of related to this stage of sleep. Now, I'm asking you, have you ever witnessed, experienced, so now or might be in your childhood, that you are dreaming, it's a nightmare, and then suddenly you wake up, and for a few seconds you feel that you are unable to move. Has that ever happened to anybody here? You can raise your hand. Never.
Sir, please repeat.
You're not able to move.
Yeah, for a few seconds. I can't move, and then it's fine. You have had a vivid dream, say a nightmare, a bad dream. You suddenly wake up, and you try to shout or you try to move, you can't do it for a few seconds, and then it's okay. Has it happened? Yeah, for a few seconds.
More time.
Okay. So this is called hypnagogic hallucination, and this happens because you are dreaming in the REM sleep. It is normal. People can get this occasionally, and it's quite normal. It can be abnormal in certain conditions. I don't think it's sort of there's about scope to discuss about that. But this what happens is because you are dreaming in the REM sleep, your body was paralyzed, and you suddenly wake up. Your brain is still in the REM sleep phase, and therefore the muscles are paralyzed, and then suddenly the brain switches, and you are fine. Okay. So if you look at the normal sleep architecture, you are sort of asking about this. You can see a person goes through the stages. So stage 1, 2, 3, 4, and REM. You can see that REM comes at regular intervals. Now what will happen if you wake up here? We'll come to that. If you wake up, say you don't move on to REM phase, you wake up here. Will the sleep be refreshing? No. I'll come to that, what happens. REM is rapid eye movement sleep. And this is a normal hypnogram we call when we record sleep. So you can see it's the same as the slide I showed you before, stage 1 and the REM. And this is an abnormal hypnogram where the sleep is interrupted. So if you wake up here, you go to sleep again, isn't it? So you wake up after half an hour or 1 hour. You need about 1 hour 40 minutes to reach to the REM sleep. About 1 hour from the 1 hour 40 minutes from the onset. It varies from different conditions. But if you wake, say, after 1 hour, you haven't reached the REM phase, and then you go to sleep again. And then you wake up after another, say, 1.5 hours. So what's happening every time you are waking up, you are not completing the full sleep stages or cycles. And this is called fragmented sleep, and this is bad. It's bad because you need all the 4 stages of sleep for proper neural, endocrinal functioning of the brain and for the proper restorative function of the cells. So this is an example of fragmented sleep. Now, sleep disruptions and disorders. There are about 70 clinically recognizable sleep disorders.
Does it mean at least one REM should be there in your sleep?
Not at least one REM. It depends again on your sleep requirement. If your requirement is 6 hours, you need at least 2 REMs. But there is no such study which says that how many REMs exactly you need. I mean, no one can. It's very difficult to sort of find out by research.
Is this specific to humans or
Not sure.
the cat, dog?
Not sure. Not sure.
But then what happens in villages? So normally, there the cattle will be there and the people will be sleeping outside. So normally get up maybe half an hour, 1 hour, they get back to sleep, and again go back to sleep.
Yeah,
it's wrong.
It's bad practice.
It's bad.
Bad practice.
But then, sir, again, what would be the reason why people have different, sleep duration? For example, say there are people who can sleep only for 4 hours.
Nobody knows. Nobody knows. We don't know people with same condition, with same severity, treated with same antibiotics, same infection. 5 people will respond differently. Why? We don't know. It's the individual body response. And that's why there are so much gray areas. So insomnia, as you know, inability to sleep or inability to maintain the sleep. It's not only difficulty in sleeping or going to sleep, but it's also shallow sleep or inability to maintain a good sleep. Narcolepsy is one of the conditions that suddenly patient feels an irresistible desire to sleep and will fall asleep, but is refreshed after half an hour nap. So it's a genetic condition. So mainly the problem here is in the brain, and the patient falls asleep and can drop down while talking. I mean, it's sort of another area. Restless leg syndrome is very common. Now, how many of you experience, say you are sleeping, and then you feel, oh, it's probably itching in my leg. So you move the position of the leg. It's relieved for 5-10 minutes, and you feel, oh, it's itching or something crawling on your leg. You change the leg position again. Anybody felt this? Huh? This is called restless leg syndrome. So what happens is, it's an irresistible desire when you have to move the leg to get relief from the symptom. And it's a sort of curious symptom. It's not, what I will say, it cannot be described, but something crawling or creeping or itching. And there are some conditions which can cause restless leg syndrome, like anemia, particularly iron deficiency anemia, thyroid disorders. This can, or kidney failure can cause this sort of problem. So what happens? The person is actually not sleeping then. And it is because of the leg problem, not anything with the sleep. And then we have got parasomnias. Parasomnias are mainly REM sleep disorders. It happens during the REM stage.
What are those people who are walking during sleep?
Come to that. Sleepwalking. And this is a huge area, as I said. I mean, it's very difficult. So insomnia, as I said, transient, can last only a few nights. You might be stressed. There might be other anxiety-related problems or any other problems. So you can have a transient insomnia. Short-term insomnia can be for a few weeks, whereas chronic insomnia is more than a month. So if anybody comes to me and says, "Doctor, I couldn't sleep for last 2 or 3 nights," forget, don't take sleeping pills. Because there is reports that if you take regular sleeping pills, it can increase the chances of dementia by more than 50%. And studies have shown. And it's not a good practice to take sleeping pills. It can also cause depression. Narcolepsy, I will skip that. Restless leg syndrome, as I said, tingling, crawling, or picking sensation, it's a major impact on sleep. And if your nighttime sleep is disrupted, then you are sleepy during the daytime. Simple. Now, parasomnias. It's actually what happens. I mean, the explanation is complex. I'm not going to the explanation. But what happens is there are several conditions called sleep terror. Person suddenly wakes up and then cries, shouts, like fear, as I said, but doesn't remember. So it's a partner or whoever is sleeping, the person tells, "Oh, you were shouting at sleep terror."
So
Sleep talking.
What is the reason behind people behaving or say?
It's a very complex. It's very complex inside the brain. It's a mechanism. It's no reason. Some people have that. There's no.
Could there be no relation with their
With any diseases or anything.
Oh yeah, the past experience could be, say, a person was subjected to the physical torture or say
No. It's not always.
Okay.
Not always. Sleepwalking. And you can see, I told you that this REM sleep, you get paralyzed. How can a patient walk in REM sleep? But it happens. So these explanations, these are very curious and very difficult to explain, but its mechanisms are very complex. I mean, it's sort of beyond the discussion of sort of in this group. So this actually happens during the REM sleep. But most of these are benign in the sense that they don't have any long-term effects. You get my point? Yes, sleepwalking is bad because the person might walk out of the stairs in the night. So you have to restrain the person, make sure. But it doesn't have a long-term impact. Sometimes it can cause depression. These are associated with depression. And now I come to one of the very important sleep disorder breathing. Now have you heard of obstructive sleep apnea? You have. I will discuss about obstructive sleep apnea in a little bit because that's very important and that's most of the sleep disorders we see. Yeah, it's related to snoring, but snoring and obstructive apnea are not same. And also, I think obstructive sleep apnea and insomnia are two of the most common sleep disorders. But when I say sleep disordered breathing, that comes to either obstructive sleep apnea or central sleep apnea, a chain stroke breathing, and low sort of hypoventilation means is what I would say the amplitude of breathing is low, so you're not having a full breath. So what is obstructive sleep apnea? So if a person is lying on his back, and if you're looking from the side, you see when the person is breathing, this is the airflow. Clear? Now this is the uvula, which you see at the back of your throat, that bit which moves. You can see the end there. Now what happens is during sleep, the tongue, this is the tongue, falls back. It blocks the passage. It happens only during sleep. And as I said, I'm not going to explain the reasons, but there are lots of reasons It could be an anatomical abnormality, it could be a problem with the ventilatory drive. Have you heard of the term loop gain? It's an engineering term. Loop gain. So, I mean, what loop gain is, I'll explain it later. And what you treat is with the CPAP. I will come to that. So, this is obstructive sleep apnea. Whereas in central sleep apnea, it's the brain that stops signals to the breathing muscles. So, there is no airflow and there is no obstruction there. This is called central sleep apnea. Comes from the brain. Whereas obstructive sleep apnea is due to obstruction at this level. As I explained, so it's collapse of the soft tissues at the back of the throat, and upper way and tongue during sleep. So apnea, the term apnea means not breathing. So you can stop breathing for few periods of time, short periods of time. Usually it's about, we calculate about 10 seconds.
How do you know that someone is having a sleep, obstructive sleep disorder?
By sleep study.
No, I mean, okay.
I will come to that. I have to give it some time. Huh? So here, because there is obstruction, the person is trying to breathe, giving the effort. But because of the block, air is not passing through. And then what happens? The brain senses this. Two things, that there is no airflow going to the lungs and the person is making an effort in the sleep to overcome this obstruction. And therefore the brain wakes the person up. As soon as the person wakes up, it opens up. Now this waking, the person might not remember. Some waking he might remember, some not. Most of the waking the person doesn't remember. So what happens? The person falls asleep again and the cycle repeats. So what will happen? The sleep gets fragmented. Doesn't complete the full stages of sleep. The main problem. So in Indian studies, so OSA, different studies have shown a prevalence of about 4.5% to more than 13%. It depends on the population studied. Whereas the global prevalence is from 0.3% to 5%. And you know, I mean, there are obvious reasons. It's self-explanatory. There's a lot of OSA in children. It's more common in men, women after menopause, and people who are over the age of 65. As I said, can also occur in children. Most of them are due to anatomical problem of the short neck, retracted lower jaw, which compromises the space there. So if the jaw is pushed back, then the whole thing is pushed back and that space is narrow. So any sort of falling back of the tongue, slightest, will block the airway. But however, obesity and so what symptoms would you have? Any idea? Do you know anybody who has got obstructive sleep apnea?
I don't know how to detect.
You know?
At home, we don't know how to detect if someone is having it.
No, you don't know, but you might be knowing any person who has been diagnosed to have OSA and having treatment. No. Right, okay. So it's more common, as I said, with obesity, increasing age, male gender, as I said, anatomical problems, abnormalities of the upper airway, strong family history, using sedatives or alcohol because that makes the muscles very lax and therefore the tongue tends to fall back easily. Smoking and some associated conditions. So common symptoms. Few symptoms you will be having is, number one, snoring. Snoring, obstructive sleep apnea patients will have snoring. But snoring doesn't mean that the patient has got OSA. So it's a gradation, simple snoring, heavy snoring, then the person develops gradually this sleep apnea. And gasping or choking sounds. Sorry? Yes. Snorers have more serious health implications than non-snorers. There are lots of evidence for that.
It obstructs oxygen.
No, not a simple snorer. Obstruct the OSA is only if OSA is not present, then oxygenation is not compromised.
What is the study which says that how many people snore at morning? Is there some study? I think
About, sorry?
the percentage of population who snores and who do not.
Look, this study will be, even if the study is done, it will vary from population to population.
I think it's widespread. That's why
It's widespread. It's widespread. It's not.
Most of us snore.
Yes, Indian population snore more than many of the Western population. But if you look at the US population, they snore a lot. But not the European.
Why?
Huh?
It is hereditary.
There are many, no, it's a weight. Weight is one of the most, and nasal blockage, one of the important cause. And there are other factors as well. Alcohol usage, as I said, that can cause increased your snoring.
If everybody snores, then how does it impact the health?
It impacts.
It's common.
What
with everybody.
What we see is, we look at the prospective study of snorers versus non-snorers, and we look at eliminate the other risk factors and see how many of the snorers develop these conditions and how many of the non-snorers develop those conditions. And there is a clear statistical relation between snorers and the medical problems. Eliminating by the other risk factors.
Usually kids do not snore.
Yes, they do. They snore. They snore if they have particular problem, particularly when they have got a cold. They snore. If they have got a big tonsil or adenoid, they snore. If they are obese, they snore. If they have got anatomical abnormalities, they snore.
But snoring usually develops in the later age.
Usually develops in the later age. So, what complaints the partner make is heavy snoring, and then suddenly all sounds stop. And then the person wakes up with a gasping or choking sound like, and then the problem, the cycle starts again. Falls asleep and the snoring starts. So what happens actually is snoring, then obstruction, no airflow, so silent. Then person wakes up, obstruction opens and goes to sleep again. This is a typical history in a patient with obstructive sleep apnea. So the patients wake up in the morning, non-refreshing sleep. Oh, I need to be on bed more. I feel the sleep is not refreshing. So this is one of the symptoms. They tend to get morning headache. They tend to go to the loo in the middle of the night 2 or 3 times. Not all patients will have all symptoms, but most of them will have this, and they are sleepy during the daytime. This is worse if the patient has taken alcohol or sedatives, if there is a nasal blockage. If there is a nasal blockage, what happens is, if the person is trying to breathe through the nose, which is blocked, is generating a more negative pressure inside the mouth, and that causes collapse. It's just like buckling of the tubes, the muscular tubes inside. So narrow tube, if you pull it like that, the tube buckles in, isn't it? That's what it happens. They tend to get fatigued in the day, and they tend to get memory problems and cognitive functions, difficulty in remembering, not performing well. So this is the effect on the quality of life. So however, more serious implications. Number one, traffic accidents, performance at work, high blood pressure, heart disease, stroke, diabetes, early death. And these are the consequences of obstructive sleep apnea. So you can see if you've got insulin resistance leading to diabetes, weight gain, nocturia, sexual dysfunction, memory and cognitive functions, concentration problems, premature aging, depression. You've got all sorts of heart problems, including high blood pressure, and you've got excessive daytime sleepiness, fatigue-related accident, and headaches. International Diabetes Federation consensus statement: OSA patients should be monitored for type 2 diabetes and vice versa. OSA patients should be routinely screened for type 2 diabetes. So who should be screened? So we need to screen everybody. I cannot do sleep study on everybody. So I have to know which patients are the target for sleep study. I'll come to the sleep study. So all adults who answer yes to other question. Do they have daytime sleepiness? And are they dissatisfied with the sleep? And patients with risk factors, particularly, I mentioned a few. Retrognathia is a small jaw which is back. And there's a family history of OSA and obesity. The BMI, you know the BMI? The calculation, so 35, more than 35. And this is a screening tool. You can all use this tool if you want to. It's called a stop bang questionnaire. It's an internationally validated questionnaire where they have to all take whether it's yes or no. Now I can leave the slide for say 15 seconds and you can mentally score from this. This is the most important, but this is also added. And you can see what's the risk. First is you snore loudly, which is heard from the other room or behind the closed door. Often feel tired, fatigued, or sleepy. Has anyone observed you stop breathing during your sleep? Do you have or are you being treated for high blood pressure? BMI more than 35, you can calculate. Age over 50. Neck circumference as a collar size more than 40 centimeters. And male gender.
So this is kind of a tool.
A screening tool.
So we can use it on our.
Yes. It's validated. It's not my sort of tool. It's there are lots of sort of all the sleep centers use this. There are other Berlin questionnaire, but that's more elaborate. We tend to use a stop bang, which is very user friendly. So stop means snore, tired, OP. Stop and bang is BMI, age, and these are mnemonics. And this is the sleepiness scale. It's called Epworth sleepiness scale. So you are given a situation. So see, the situation is sitting and reading. And now you have got 4 options, 0, 1, 2, 3. Now in this situation, your chances of falling asleep, 0 is never and 3 is high. Now you score and make the total score. And we assess that because when we treat sleep apnea patients, this is one of the important features that an indication for sleep apnea treatment in the absence of other factors. And this affects the quality of life. Once a patient finds that the quality of life changes, it's more compliant in using the machine. So the situation, sitting and reading, watching telly, sitting inactive in a public place, as a passenger in a car, lying down to rest in the afternoon when circumstances permit, sitting and talking to someone, sitting quietly after lunch with alcohol in a car. This is while driving, while stopping for a few minutes in traffic. This is called Epworth sleepiness scale. So OSA is diagnosed by a sleep study. the wear of the patient, like ECG, but more elaborate than that. There are brainwave recordings, there are recordings from the nose, there's airflow, there is a sound recorder to record the snoring, there is recording of the abdominal and the chest muscles, the effort. And we find out from the sleep study, it can be done at home, it can be done in the hospital, and there are sort of smaller, we call it level 1, level 2, level 3, depending on how elaborate we want the test. If the patient has got a very fat patient, obvious snoring, dozing off in the OPD, yes, it's a high risk, it's noise. So we can do a quick screening test. Or anyone with a thin, no history, but the patient wants a sleep study, very unlikely to have sleep study, we can do a screening test. Otherwise, the ones in between, they need a proper polysomnogram or a sleep study. So the treatment is, of course, lifestyle changes. What are the lifestyle changes? Firstly, lose weight. There's enough evidence that sleep apnea improves by 30 to 40% if you lose weight. However, it might not go away completely once it sets in. Secondly, sleep on your side. There's less chance of the tongue falling back if you sleep on your side. In some patients, during sleep, they sort of unknowingly move on to the back. So there's a practice of strapping a tennis ball at the back, so that the patient cannot lie on the back. And that's a strategy that's followed. Keep your nose open. If you have got dust allergy, like allergic rhinitis, use nasal sprays. Then avoid alcohol, sedatives at night, as I said, and consult a doctor. Okay. And what we treat is the gold standard of treatment is CPAP. CPAP is actually, I showed you the picture, you fit the mask and drive the room air at an increased pressure. If you are blowing up a balloon, what you do is you forcibly put air and it stretches. Similarly, the machine drives the air at an increased pressure and it forces open the airway and keeps it open. Sorry. You can have some surgery, but surgery sometimes might fail, and there are specific indications for surgery. Not all patients are for surgery. You can have mandibular advancement device, what is fitting a custom-made brace to your jaw, and you tighten the screws on the side so that the jaw is advanced during sleep, and that opens up the posterior space. If there are enlarged tonsils or adenoids, you remove them, and there are other surgeries as well. So I will finish that. So always, with sleep apnea, always look for these symptoms. Weight loss is very important, and particularly neck circumference, as I said, collar size, and that matters a lot. And I'm seeing quite a few young patients, particularly in the IT sector, are having these sort of problems, obstructive sleep apnea. And once it sets in, it's a risk factor for several metabolic and cardiac conditions. So that needs to be addressed. It has got more health implications than probably any other sleep disorders. Okay, thank you very much.